Good morning, friends. I welcome you all for this instruction course. It is very surprising to me that on day one at 11 o'clock, the hall is almost 90% empty. So it seems that most of the people who comes to attend the AIOC is for socialization rather than the scientific content. But anyway, we have to do the job, and whosoever are there, I hope that they would be benefited by this course. This course would be dealing about the demystifying the glaucoma suspect. At the outset, let me thank Dr. Namrata Sharma, the Chairman Scientific Committee, for having given us this opportunity to present our work in front of you people. And I'm sure that you would be benefited by this course because we have a galaxy of speakers, luminaries in glaucoma. Dr. Harsh Kumar is there, Dr. Manisha is there, Dr. B.K. Nayak is there, Dr. Vinay Nangia is likely to join us soon, and Dr. S.S. Pandav is doing another course in another hall, but he would be joining us very shortly. So we know that glaucoma is a chronic blinding disease, and overdiagnosis and underdiagnosis is very common. So we are not going to deal with the underdiagnosis, but mostly the overdiagnosis. How do we diagnose glaucoma? The first thing is the intraocular pressure, then is the optic nerve head examination, then is the gonioscopy, then some important tests, the gold standard perimetry, and to assess the structural damage in glaucoma, we do the OCT. So we try to cover all these things, where these things can possibly misguide us to diagnose glaucoma appropriately. So I would be talking on ocular hypertension. Dr. Harsh will deal with the optic nerve head and the normal tension glaucoma. Then Dr. Manish would be talking on the gonioscopy. Dr. B.K. Nayak will deal with the gold standard test for glaucoma diagnosis and follow-up, that is standard automated perimetry. Dr. Pandav will deal with the OCT, and last lecture will be by Dr. Vinay Nangia, who would be dealing with myopic disc. Because it is said that all the myopic patient should be considered as a glaucomatous until and unless proven otherwise. So that's why I thought that it should be one of the important topic in this course. And Dr. Nayak is doing lots of work on this. So he is the right person to deal with this topic. So let us start with the first topic, that is this demystifying the enigma of ocular hypertension. Let us try to understand it's not moving forward. Okay. So, what is ocular hypertension? The normal intraocular pressure in any individual is around 15.5 or 16 millimeter of mercury, plus minus 2 standard deviation, which comes to the range of around 10 to 21 millimeter of mercury. So the patient who have the intraocular pressure of more than 21 millimeter of mercury, but without any sign of having glaucoma, falls into the category of glaucoma suspect. If you talk about the prevalence of glaucoma suspect, then almost around 10% of the population above the age of 40 having ocular hypertension. This is based on most of the population-based studies. But it is not all the time when you measure the intraocular pressure more than normal that the patient should have the ocular hypertension. There might be some other reason as well. Maybe the erroneous reading while you are measuring with the different equipments. The most notorious amongst all is the NCT, but even the gold standard Goldman applanation taurometry can give us the erroneous reading. If the Myers are too thin, then erroneously we record the high intraocular pressure. Almost all of us knows very well that thicker is the cornea, higher is the intraocular pressure. So that one of the reason to record or to measure high intraocular pressure in the clinical practice. If there is steroid use or abuse, many patients for some or the other reason are advised to use the steroid. Some abuses the steroid, and if they are steroid responder, then it could be one of the cause for the ocular hypertension. Intermittent angle closure glaucoma. All of us knows that the prevalence of angle closure disease in our country varies from 25 to 50% in different geographical zone. So if the patient comes to you and you record a high intraocular pressure with everything normal, then it's quite possible that it might be the intermittent angle closure. So the landmark study to deal with the ocular hypertension is the OATS trial, what popularly is called as, that is a ocular hypertension treatment study. That study was performed on a very long-term basis with a large population. Almost 1,600 plus patients were recruited. Initially, in trial 1, there were 3 trials, 1, 2, 3. In trial 1, they were followed up for 8 years, and there were 2 arms. One was the treatment and another was the no treatment. And it was compared whether the treatment was beneficial to them or not. All the patients, they had ocular hypertension with a gonioscopically open angle. So this cumulative curve says that on 7 years of follow-up, almost 4.4% patient progressed to POAG from treatment group, and almost 9% patients progressed to POAG in a non-treatment group. So if you see this, you find that almost 90% of the patient will not progress to POAG on 7 years follow-up if you will not treat them. So why to treat all 100 patients? Just to give benefit to 10% patient? Then let us see, there is trial 2 and trial 3 as well. The trial 2 was started in 2002, where there were not 2 arms, and all the patients, whosoever were recruited, were given the treatment. And in trial 3, which was done between 2016 to 2019, they did the assessment of the functional and structural damage in these patients. And the outcome was, in the one group, 41%, the initial non-treatment group, 49% patient progressed to glaucoma, and in the treatment group, 41% patient developed to POAG. So there was, though not significant difference between the 2 groups. So again the question comes that if the 50% patients are likely to develop glaucoma, but on 20 years follow-up, so should we give them medication when there is not much difference between treatment and no treatment group over a period of time? But about 296 patients out of 1,500 patients require more than one intervention in the form of either SLT or surgical treatment. So to find out which patient may progress to glaucoma, we divided the patient into three groups: the low risk group, the moderate risk, and the high risk. So most of the patients who progressed to POAG belong to high risk group, and the patient who did not progress to POAG on 20 years of follow-up, that is a very long follow-up, were of the low risk group. Which patient will fall into this group? So the older age per decades, the larger vertical CD ratio, disc hemorrhage, higher IOP at the presentation, thinner corneal thickness, very high risk, family history of glaucoma and myopia. Other risk factor could be pseudoexfoliation and pigmentary dispersion syndrome that you have seen multiple times, the association between thinner cornea and high intraocular pressure. So the other patient, apart from these high-risk patients, who may need treatment, the patient who have a high intraocular pressure, more than 30 millimeter of mercury, patient with more than 25 millimeter of mercury with any of the high-risk factor, patient with more than 21 millimeter of mercury with venous occlusion in either eye, and preferably the precious eye patient should be given a chance to treat them. Which patient will progress faster? We do not know yet. Next, come to the steroid responder. So any form of steroid given to the patient, whether it's a systemic or the local, if they are steroid responder or GLC-1A presenter, they will develop a high intraocular pressure. And you have to withdraw the steroid, and sometime it's quite possible that you may have to do the surgical intervention. The intermittent angle closer, Dr. Manish Shah is going to deal in detail. I will just describe two patients very briefly of ocular hypertension, then how they behave. This patient, the disc looks like a glaucomatous disc. You can see over here, inferior conus, high intraocular pressure and high central corneal thickness. So this superior arcuate scotoma was correlated with the inferior conus, and the same thing was in the nerve fiber layer analysis. But this patient was followed up for more than 10 years and he did not progress without treatment. But there is another patient where there is a high vertical CD ratio in one eye. This patient was also given a chance and was not treated, normal visual field, but you can see that there is a RNFL defect a few years later and the vertical CD ratio has enlarged. So this is an important point, that this patient has a high risk factor and that's why he has progressed, and there is a superior arcuate scotoma as well. So how to proceed with this patient? Obviously, yes, the good history taking, including the use and abuse of the steroid, is very important. Detailed slit lamp examination, including the gonioscopy, is very important. Thorough examination of optic disc and RNFL. Diurnal variation is important because we must know the peak and the trough. It's quite possible that the maximum IOP in the office hours is a trough IOP for that particular patient. CCT, yes, we know that it is important risk factor if the cornea is thinner. And we have to do the baseline functional test like the standard automated perimetry and the OCT. So if your patient is at the low risk, then do the serial follow-up. Do not treat the patient. If the patient is with the high risk, then the close follow-up is required and you may decide at your discretion whether to treat or not. The gonioscopy and DVT is must in all these patients. Baseline investigation like ONH photos and standard automated perimetry and OCT has to be done. Close follow-up with good clinical examination for long term is very essential in these patients, because we know that over a period of time these patients progress to glaucoma. So we have to be very, very careful about this. Thank you very much for your patience listening.